Next is radiation-induced bowel injury. It all includes enteritis, colitis, and proctitis. How does radiation-induced bowel injury present? So again, it's a very broad question. It is characterized by symptoms of acute inflammation, predominantly in early phase, and fibrosis in the late. There is a wide spectrum in the onset, duration, clinical course, duration, and outcome. It can present early within days of treatment in the form of anorexia, nausea, mucositis, vomiting, cramps, diarrhea, and tenesmus, mucoid discharge, and rectal bleeding. Most symptoms are self-limiting and resolve in 2 to 6 months. It can present late, several months to years after radiotherapy. So obstruction, it can present as obstruction, so colic, abdominal pain, vomiting, distension, absolute constipation. Malabsorption, watery diarrhea, steatorrhea, and weight loss. Short gut syndrome, bile acid mediated diarrhea, bacterial overgrowth, impaired gastrointestinal motility. Fistula, feculent vaginal discharge, recto-vaginal fistula, or pneumaturia, which has colovesical fistula. And chronic inflammation, mucositis, gastritis, dysphagia if esophagus stomach involved, tenesmus, mucoid, rectal discharge, and rectal bleeding if rectal involved, sepsis, abscess, and recurrent infection related to fistula, UTI from the colovesical fistula. What are the clinical signs? Again, weight loss, malnutrition due to malabsorption, abdominal tenderness, peritoneism, inflammatory and perforation, abdominal mass, inflammatory and sepsis, distended abdomen with tingling bowel sounds, bowel obstruction, rectal tenderness and bleeding, rectal involvement and dehydration and sepsis, systemic sepsis. What are the risk factors for radiation-induced bowel injury? Disease-related factor: up to 50% of the cancer is treated with the radiation. Cancer of esophagus, stomach, cervix, prostate, and rectum. The intestines may be exposed to radiation. Next is treatment-related factors. So given the dose dependency effect, the dose of radiation is important. Others include the length of the bowel irradiated, use of dose fractionation, chemotherapy, and the mode of delivery. For example, brachytherapy and beam radiation may reduce bowel injury. Patient-related factors: hypertension, smoking, diabetes mellitus, atherosclerosis, suffer increased risk for vascular injury. Low BMI patients at extreme age groups, very young, elderly. Genetic predisposition, ataxia, telangiectasia, increased risk of radiation toxicity. Previous abdominal surgery resulting in adhesion that fixed intestine to the radiation field. How would you diagnose it? Again, plain X-ray will show the airflow level obstruction, and thumbprinting for mucosal edema or colitis. Barium contrast studies provide mucosal detail and document the presence of fistulae, fixed loops with poor distension, absent hospital marking, diffuse mucosal ulceration, or a single ulcer may be seen. A CT scan with contrast will confirm the bowel obstruction, and location rule out the abscess and further delineate fistula. Endoscopy, ability to take biopsies to confirm the diagnosis and rule out other diseases like infection and disease recurrence. In acute setting, perform with great care. Risks of perforation fistula. Histology, friable edematous mucosa, ulceration and inflammation. Chronic changes include fibrosis, smooth strictures, and pale granular mucosa and submucosal telangiectasia. How would you treat it? The treatment should be individualized and largely medical. For acute symptom control, consider antidiarrheal agents, antiemetic agents, and bile sequestering agents, and 5 aminosalicylic compounds. Consider steroid regimen for colitis and proctitis. Consider endoscopic ablation with argon beam coagulation or rectal 4% formalin instillation for radiation proctitis. Surgery is usually for the last resort for complications like perforation, obstruction, abscess, drainage, and fistulae. Options include drainage, direct repair, resection, bypass, and proximal event due to higher risk of poor wound healing in irritated tissue, and a less if more approach is preferred. Thank you.